Okay, guys, let's get started with chapter 3. It's a long chapter. Fluid electrolytes, acid base, and IV therapy. I'm going to kind of give you an overview. I want you guys to be in the book reading these chapters. This is chapter 3. There's a lot in here. You guys are going to need to know the normals for those electrolytes. And I'll show you a way in class to remember them, but you're going to have to start working on those, okay? So the first thing we're really going to talk about is the function of water in the body. Remember that a normal adult has 55 to 65% water in their body. It's used for transportation, heat regulation. It's a medium for enzymatic action of digestion. We have to remember that the old and young have more severe issues with water, loss of water, excess water. Infants are 77% water, and older adults are only 45% water. We also have to remember that women have less water than men. Fatty tissue also doesn't have as much water as other tissues, so the higher the fat content, the less water that we have. All nutrients have to be dissolved in water for a cell's life process to take place. They need water. Very important, right? So water controls the distribution and regulation of body fluids. Our bodies have a thirst mechanism. We have osmoreceptors in the hypothalamus that sense our internal environment. ADH comes from the posterior pituitary gland and regulates how much fluid leaves the body. Aldosterone and ANP help regulate reabsorption of water and sodium. And baroreceptors in the carotid sinus and aortic arch detect pressure changes in the body. There's a box on page 30 that will help explain that a little bit more. Another review on the movement of fluid and electrolytes, right? I know you guys remember passive and active transport. Passive transport does not need energy. It is based on an area of greater concentration going down a concentration gradient to an area of a greater concentration to lesser concentration, right? So diffusion, the example that we used in anatomy was a perfume that we sprayed that would eventually get across the whole entire room. Osmosis is the movement of solvent or water across the membrane. When there's difference in concentration of fluids in various compartments, osmotic pressure, which holds the fluids in the vascular spaces, will move water across the membrane to equal them out. And filtration is also passive transport, doesn't need energy, but our body's example of that is the kidneys, because the blood pressure is the driving force behind that. Active transport, and here's your slide about the passive transport. Active transport requires energy. It moves molecules against a concentration gradient, so it can go from an area of lesser concentration to an area of greater concentration. And a big example in our body is the sodium-potassium pump. So the first thing we're going to talk about is deficient fluid volume. Risk factors include impaired swallowing. If they can't swallow it, they can't get fluid in, right? If they're too weak to get up, they can't get to the sink to get a glass of water or to the refrigerator. If they're disoriented, if you guys work in a place that has people with dementia, they don't remember to get a drink, you have to offer it. Or maybe they just can't keep water in. They're vomiting, diarrhea, hemorrhage, whatever's happening, they can't get it out. Or they can't keep it in. Signs and symptoms are just what you would think they would be. Thirst, poor skin turgor, dry lips, tongue, mucous membranes, sunken eyeballs, weak, dizzy. They might have orthostatic hypotension, weight loss. They're going to have dark urine. It's concentrated with a high specific gravity. It might have a smell. Skin turgor for a normal adult is a pretty decent way to check for hydration. In an elderly person, it's a little bit trickier because they lose elasticity, and we measure elasticity with skin turgor too. So the best place to check for an older adult is on like their collarbone. So you pinch gently, pinch. And if their skin immediately, retracts back to normal, then they're fine. If it takes a little time to do that, they might be a little bit decreased. If the fluid deficit is present, the skin may remain elevated or tension for several seconds. But we still have to be careful with elderly. It's not the end-all test. Not the absolute best way to check. Other signs and symptoms include thick saliva. They might have a fever. They will have flat neck veins. They might have a rapid, weak, thready pulse. And they would have an increased hematocrit. So the hematocrit will be adjusted because of the level of fluid in the body. So what do? We want to make sure that we're increasing fluid intake or decreasing fluid loss. We want to maybe send a nurse's aide in there to offer at least 4 ounces of water every hour. We need to make sure that, especially if we have an older adult, we're really paying close attention to their level of fluid, because with an older adult, thirst is actually a late sign of dehydration. So nursing management of nausea and vomiting. Pathophysiology, what is causing it? What kind of assessment do we have to do? Well, what is causing it? We're not always sure. But one thing that we can do as nurses is make them NPO. If their stomach is already upset, we don't want to make things any worse. So keep them without food and water. You won't see the complementary therapies in the hospital so much, but you probably see them if you're doing home health. Those pharmacologic measures, again, those things along with, Zofran, Phenergan, Compazine. Signs and symptoms that go along with nausea, vomiting, abdominal pain, pallor, diaphoresis, cold, clammy skin, excessive salivation. Nursing management of nausea, vomiting. Again, we're going to have the patient lie down, maybe turn on their side, or put their head between their legs. We're trying to keep them from aspirating. We need to help them out, hold that emesis basis for them, maybe put a cool washcloth on their face or neck. We want to have them breathe through their mouth so they're not smelling the vomit. Provide mouth care after the episode. If they don't have to be NPO, sucking on a few ice chips might be helpful. Not 4 cups full of ice, 5 or 6 ice cubes. We try to keep the environment that they're in quiet, cool, and odor-free. And if their nausea and vomiting persists, we need to watch them for dehydration. With older adults, we want to be very careful how we rehydrate. We don't want to go too fast and overload them, especially if they have cardiac problems, because overloading is way worse than not having enough. So we've got to go really low and really slow. Diarrhea. Pathophys of diarrhea, typically it's irritation of the intestinal mucosa. Chronic diarrhea is things like UC, irritable bowel, allergies like mine to gluten, lactose intolerance. It can also be a blockage. If there's an obstruction to the flow of intestinal contents, the liquid will seep around the impaction. Diarrhea can cause considerable potassium and sodium loss. It can cause dehydration, malnutrition, anemia. Signs and symptoms: frequent watery BMs, abdominal cramping, generalized weakness, and extreme diarrhea or bad diarrhea is 15 to 20 times a day. So what do we do? Limit the intake of foods to help rest the bowels. If they have oral feedings, we would start with clear fluids and progress to full liquids and then solid foods as ordered if they tolerate. We want to make sure that when we're giving them something to drink, that the drinks contain glucose and electrolytes. We want to avoid very iced fluids because it can cause irritation in the stomach and intestine. We want to avoid carbonation, whole milk, raw fruits, and spicy foods. Sometimes we will treat diarrhea with kaopectate or Pepto. Remember, if you're giving your patient Pepto, though, that it will turn their stool black and it can turn their tongue black, and we need to make sure that they're aware so that they don't freak out when they see that. You may give them antibiotics or something to help with the infection, but many times they don't treat diarrhea right away because they want whatever organism is in there to clear itself out. If they have excessive fluid volume, that means too much fluid. They can have water intoxication. Impaired elimination can cause it, like renal failure. They can't get rid of it. So we would do a hematocrit to check because that measures the percentage of red blood cells in whole blood. If there's excess water, the hematocrit will be less. Urine-specific gravity is another way to tell. Normal urine-specific gravity, or urine-specific gravity is actually compared to distilled water. Distilled water specific gravity is 1.000. Normal for adults is 1.003 to 1.030, and you see the average there. So our urine is mostly water, but it has some urea, some electrolytes, some other stuff in there. Okay, edema. Pathophys of edema. Edema is just the accumulation of freely moving interstitial fluid that is associated with the retention of water, sodium, and chloride. Remember, wherever sodium goes, water follows. We can have edema in body cavities. We can have it in peritoneal cavity, the cranial cavity, the lungs or pleural cavity, the heart. We can also see it in the sacrum. We can see it as periorbital edema, which is around the eyes. Their hands and feet can be swollen. We have to remember, if we see it in the head, the lungs, or the heart, that those are life-threatening. For general causes, with loss of plasma proteins, the osmotic pressure has decreased, which allows the fluid to leak out of the vessels. With obstruction of lymphatic circulation, we would see lymphedema. An infection or inflammation causes an increase in capillary permeability and an increase in capillary hydrostatic pressure, which can cause pulmonary edema. Can also cause third spacing. Third spacing is when the whole body is swollen, right? So that's a result of trauma, burns, nephritis, or sepsis. How do we check for edema? We press over a bony prominence for 5 seconds. Doesn't have to be real hard. After 5 seconds, if there's just a mild indent, but really the ankle doesn't look swollen, that's a +1. Moderate would be an indent that subsides quickly. Deep would be an indent that remains for a short time. The leg actually appears pretty swollen. Very deep, the indent lasts a long time and the leg is swollen. Generalized edema occurs when the body's mechanism for eliminating sodium fails. So it becomes life-threatening when those fluids overload the circulatory system, like with CHF. or accumulate in the lungs, as in pulmonary edema. And remember, the main sign for pulmonary edema is pink frothy sputum. So if you see that, that's a true emergency. Lymphedema is associated with lymph node removal. You'll see that in a patient who has had a mastectomy and with lymph node involvement. They might have a swollen arm. It can cause third spacing, can cause some other stuff. Localized edema is non-pitting. It does not really come and go. It just comes and then it goes. It's characterized by tight, shiny skin stretched over a hard red area. It can be caused by trauma, allergies, burns, lymph flow obstruction, liver failure. Think about getting stung by a bee and how that body part swells all up. That's localized edema. Dependent edema, we see a lot, kind of what we see all over the place. Usually it's ineffective gravity, somebody that sits a lot. You see it a lot in the elderly because they sit a lot. Can be relieved a little bit by elevating feet. If it's really bad, we usually want them to lay and position those body parts higher than the heart. So the best treatment is always to correct the underlying cause, but we don't always know what the cause is, so we're trying to rebalance their fluid content. If they might have to have a fluid restriction, they might have to be on diuretics. They might be ordered to have bed rest because their kidneys function best when we're laying down. They get the best blood flow. So usually with edema, we would have a low sodium diet. They'd have to have TEDHOs or SCDs. We'd be recording their I's and O's. We'd be getting daily weights. If our patient was at home, we need to make sure that we are documenting or teaching them how to document that stuff, how to keep track of their I's and O's, how to keep track of their symptoms. Those daily weights are important. They have to be done at the same time every day. If they keep on gaining weight, then whatever they're doing isn't working and they need to call their doctor. Osmolality is the concentration of the solution determined by the number of solutes. Those solutes don't have to be electrolytes. They can be other things, protein, urea, glucose, etc. Electrolytes are just molecules in solution. Y'all remember anions and cations? Anions are negatively charged, cations are positively charged. And electrolytes have electrical impulses, right? They can conduct an electrical charge. Here's your question. I want you guys to look at that. I will give you some answers when we have class together, okay? Okay, electrolyte imbalances. Guys, I'm going to do a quick overview of these electrolyte imbalances. There is a great chart in your book. The normals are on page 39. There's a table on pages 40 through 42 that is really a great resource for these imbalances. Hyponatremia is low sodium. Can be caused by either sodium loss or too much water because the water would dilute the sodium, right? So a lot of times an issue with CHF, liver disease, chronic renal failure. Signs and symptoms, central nervous system issues, neuromuscular changes, fatigue, lethargy, headache, confusion, altered level of consciousness, anorexia, nausea, vomiting, muscle cramp, seizure, all of that. Risk factors, if they have a low sodium diet, if they're having too much fluid or retaining fluid, if they have a loss of bile, which we don't always think about, right? But that includes nausea, vomiting, suctioning, can cause it. Weeping burns, IV fluids that don't have enough electrolytes in them. So what can we do? Because salt or water follows salt, we can restrict water intake, like for patients with CHF or kidney failure. We want to liberalize the diet. That means give them salt. A patient with low sodium diet. We're going to monitor those patients with IV solutions. Hypernatremia, kind of the opposite. They'd have good skin turgor. It can cause an osmotic shift of fluid from the cells to the interstitial spaces and cause cellular dehydration, which can cause cell death, right? Interruption of normal processes. Water loss from fever, respiratory infection, diarrhea usually is the cause. So hypernatremia, because we have too much water loss. So our fluid will be more concentrated. So the body's trying to correct the situation by conserving water with reabsorption from the renal tubules, excessive administration of sodium bicarb for acidosis. There's your signs and symptoms: dry membranes, loss of skin turgor, thirst, flushed skin, oliguria, elevated temperature, weakness, lethargy, irritability, twitching, seizures, coma, and head bleed. There's your risk factors: high sodium diet, inadequate water intake if they're confused, and excessive sweating. So something we need to worry about in the summer here in South Carolina, right? Diarrhea. What do? Increase their fluid intake, measure I's and O's, offer water between feedings, restrict their salt intake, monitor their temperature. Low potassium can cause cardiac arrest, as can high potassium. So potassium always has to do with the heart. If they have low potassium, we're going to give them potassium. You've got your signs and symptoms here. A big one with potassium is that cardiac dysrhythmias, muscle weakness, decreased reflexes. Those are kind of the big three with potassium. Risk factors: no rich potassium containing foods, right? Improper use of diuretics. A lot of diuretics cause leaching of potassium, right? So if they're on Lasix, they should be on a potassium supplement. So we want to encourage intake of high potassium foods like apricots, avocado, baked potatoes with skin, bananas, spinach, tomatoes. We want to watch for signs of DIG toxicity. We want to teach our patients to watch for signs of low potassium, administer, cater, or whatever other potassium supplement as ordered, and monitor them for I's and O's and their heart rhythm. High potassium is going to cause a fluid shift of potassium from, or causes not a fluid shift, a potassium shift from the intercellular to the extracellular space, usually with extensive burns or crush injuries. Can also, like I said earlier, cause life-threatening cardiac dysrhythmias. There's your signs and symptoms, but the cardiac dysrhythmia is usually the biggest one. Paresthesias. So if we have some kidney failure going on, intestinal obstruction, if they have addisons, DIG toxicity, diabetes, if they're using salt substitutes in their food like Mrs. Dash, high in potassium. We need to make sure we're teaching them about that. So we're going to tell them to decrease those foods that are high in potassium, administer the proper doses of insulin with our patients, and talk to them about those salt substitutes. Potassium, calcium, the big thing with calcium is that they are needed, it's needed for enzyme reactions like blood clotting, super important, right? They can have laryngeal spasms. If a patient has hypocalcemia, they will probably have hyperactive reflexes. They'll have positive Trousseau's and Chvostek's sign. Trousseau's sign, we check with a blood pressure cuff. We put a cuff on their arm, inflate it, hold it for 3 minutes. If they have a spasm in their hand, that's a positive sign. With Chvostek's, think cheek, Chvostek's cheek. If we touch the facial nerve right in front of the ear, they would have kind of a grimace or a twitching on one side of the face. That would also be a positive response. So it can occur in renal failure. Also, calcium can't be absorbed if we don't have vitamin D. So vitamin D is a huge deal. If you are low in vitamin D, you have a high probability of having hypocalcemia with it. Calcium, you can eat all you want, but it doesn't absorb unless you have vitamin D to help it, or very little absorbs. Can also have an issue with the parathyroid hormone. So if they have, somebody has a problem with parathyroid, it can also cause hypocalcemia. There's your signs and symptoms. Muscle spasms are a big one. Seizures. Cancer, inadequate vitamin D intake. Laxatives. And there you go. It talks a little bit about the parathyroid hormone. So we want them to consume sufficient calcium. Cheese, broccoli, shrimp, milk, yogurt, ice cream, however they need to get it. And we want to make sure to teach our patients to take their calcium supplements at least 30 minutes before meals so that it absorbs fully and doesn't just get flushed through the system. If they have hypercalcemia, too much calcium, this can be caused with lengthy immobilization because the calcium is released from the bone. Can also be caused if somebody's taking too much calcium and vitamin D. There's your signs and symptoms. Excess intake of calcium, if they're taking a lot of antacids. Condition that cause calcium to move out of the bone. Bone tumors, fractures, other kinds of tumors, cancer, stomach cancer, kidney cancer, multiple myeloma. But immobility and osteoporosis are huge causes. So we might need diuretics to help excrete the calcium, and we're going to encourage a high fluid intake. Hypomag is important for DNA and protein synthesis. Pretty rare. These aren't as common. But hypomagnesemia can occur with low potassium and low calcium. There's your signs and symptoms, and you see that a lot of them go along with the calcium. Risk factors: malnutrition, chronic diarrhea, bowel resection, alcoholism, thiazide diuretics, gastric suction, pancreatitis. There's a lot of patients that we need to keep an eye on. What do? Counsel our patients about their diet, monitor I's and O's. For hyper, again, pretty rare. Usually happens if renal failure or overuse of antacids. There's your symptoms. Also, aspiration of seawater, like with a near drowning, we have to watch them pretty closely. We're going to teach them to avoid laxative abuse and antacid abuse. Instruct patients with renal problems to avoid those OTC drugs that contain magnesium because they're not going to excrete it and they're going to keep it in and they're going to have an issue. So we have some other imbalances: hypochloremia, hyperchloremia, hypo and hyperphosphatemia. Let me catch up to myself. There's your hypophosphate. Signs and symptoms: can cause rickets, osteomalacia. Risk factors: vitamin D deficiency, hyperparathyroid. Again, use of antacids. Hyper, signs and symptoms: renal insufficiency. They're going to be restless, confused, might have chest pain. They might be cyanosis. But we're going to check all electrolyte levels. We wouldn't just check for phosphate. On to acid base. Okay, so acid base system. An acid is capable of giving up a hydrogen ion. A base is capable of accepting one. if we have a salt and neutralization reaction, acid reacts with bases to form water and salt. In a neutralization reaction, both are neutralized. Remember here what our body's normal is, 7.35 to 7.45, right? So we need to keep our body within that range. When our body gets out of that range, then we start having issues. pH is the concentration of hydrogen in a solution. pH actually stands for parts hydrogen. Neutral is 7. Our normal pH, 7.35 to 7.45. Anything below 7.25 or above 7.55 is life-threatening. Otherwise, we'd have alkalosis and acidosis. If we're above 7.8 or below 6.8, usually they die. Acidosis is the result of either a loss of a base or an accumulation of acid, and alkalosis is the opposite, loss of acid or accumulation of base. We have 3 ways to balance that pH, because our body needs to be within that range to maintain homeostasis. You guys remember that word? I told you you'd see it again. Without being in that normal range, our body can't function the way we need it to. So, we have buffer systems. A buffer is a substance that increases the amount of alkali or acid to change a pH in our body. In our body, we have the bicarbonate carbonic acid buffer system. So we're just trying to control the amount of each, right, in our bloodstream. The respiratory system and the renal system work together to control the balance of bicarb and carbonic acid in our body. So let's get into a little bit more detail. The bicarbonate carbonic acid buffer system is responsible for more than half of the buffering that happens in our body. There are 3 other systems that we're not going to talk about really. Phosphate, hemoglobin, and protein all help with the system. But because these buffer systems can't control the whole thing, we have some other ways to help. So let's just talk a little bit about the buffer system. So I said before, the buffer is a substance that increases the amount of acid or alkali in the solution to change a pH. The balance of those bicarbonate ions and carbonic acid ions is controlled by the respiratory system and the kidneys. Carbon dioxide, produced by cell metabolism, diffuses into the blood, where carbon dioxide reacts with water and forms carbonic acid. Carbonic acid separates to form hydrogen and bicarb as needed. The process can be reversed in the lungs that free up carbon dioxide so it can be blown off or expired along with water to reduce the total acid in the body. So carbon dioxide breaks down into hydrogen, which is acidic. Okay? So if our breathing rate goes up and we're blowing off more CO2, we're getting rid of more acid. So it would help our body blow off acid and raise our pH, right? Because remember, higher than 7 is alkaline or basic. Lower than 7 is acidic. If the lungs can't keep up with either slowing our breathing down to keep CO2 in or increasing our rate to get it off, then the kidneys kick in. Okay? So the kidneys promote the formation of hydrogen ions, which are excreted in the urine, while the bicarbonate ions are returning to the blood. The kidneys, with the influence of aldosterone, can change hydrogen ions for sodium ions. So acids can be removed in the kidneys by combining them with ammonia and other chemicals. Our urine pH can vary from 4.5 to 8 as the kidneys try to compensate for a imbalance. So our bodies deal with this constant manufacturing of acid in a number of ways. But we have to try to maintain that normal, because when we're upset, we fall into acidosis or alkalosis, and our systems get thrown off, okay? Let's see, I think I'm way ahead of myself. Here we go. Carbon dioxide dissolves. I already talked about that. The respiratory system either speeds up or slows down. And then the kidneys. They are much slower to compensate than the lungs are. So the lungs always kick in first, right? But then the kidneys have to kick in. But they are way more effective at compensating than the lungs are. It can take a few hours to several days for the kidneys to actually kick in and out. We have some acid-base imbalances that we are going to break into. Respiratory acidosis, metabolic acidosis, respiratory alkalosis, metabolic alkalosis, okay? Respiratory acidosis. Our blood gas would be lower than 7.35, so lower than normal. We'd have slow, shallow respirations. Our respiratory lungs can be congested or obstruction, causing it. Metabolic acidosis, again, lower than 7.35, so lower than normal. Causes can include shock, DKA, renal failure, diarrhea. With respiratory alkalosis, our blood gas is higher, caused by hyperventilation, so we're breathing too fast. With respiratory or metabolic alkalosis, again, we're higher than normal, but it can be caused by vomiting, excessive antacid intake, or hypokalemia. So think about vomiting. If we're alkalotic, we're too basic, we're vomiting, what are we vomiting? Stomach acid, right? So we're getting rid of too much acid and our pH is going through the roof. We are going to talk a little bit about these blood gases, what they mean. PaO2 is, normal value is 80 to 100, indicates the amount of oxygen actually being carried in the blood. PaCO2 is the partial pressure of carbon dioxide in the arterial blood. Normal value is 35 to 45. That one indicates the amount of carbon dioxide in the blood. See, CO2, carbon dioxide. pH, we talked about that. That's parts hydrogen. SaO2 or O2 sat. See that? O2 sat, SaO2. Normal is 94 to 100. This is what we're checking when we're checking somebody's oxygen level, right? This is the ratio of the amount of oxygen that's combined with hemoglobin in the blood. HCO3 is the level of plasma bicarb, an indicator of the metabolic acid-base status. Normal value is 22 to 26. You guys are going to have to know that. If we have a base excess or deficit, this will indicate the amount of blood buffer present. Alkalosis is present when the value is too high. Acidosis is present when the value is too low. With respiratory acidosis, we will have a pH that is less than 7, a PaCO2, so a carbon dioxide that is greater than 45, and an HCO3, which is your acid, would be normal. Caused by airway obstruction, pneumonia, asthma, COPD, opiate use because it depresses the respiratory rate. Here's your signs and symptoms. Management. We might have to put an airway in so that they can breathe, right? A trach or an ET tube. Postural drainage can help, sitting them up, deep breathing exercises, bronchodilators, antibiotics if they have pneumonia. But we have to be careful with any narcotics or anything that might make them sleepy because it'll decrease the respiratory rate. Metabolic acidosis. You see that these are different. The CO2 is normal, but the HCO3, their acid is low. Excessive loss of bicarb ions. from diarrhea can cause it, renal failure, DKA, hyperkalemia. Signs and symptoms. I have to know those signs and symptoms. Ketoacidosis, vomiting and diarrhea, deep, rapid breathing, or Cosmol's respirations. They may secrete urine with a low pH. You will smell fruity breath. They may have vomiting and diarrhea. The fruity breath is actually ketones, and it's really a sweet smell. And typically, if they have that, their blood sugar is well over 500. Usually we give them insulin. They might need dialysis. They probably need bicarb. And bicarb would be their first treatment. For respiratory alkalosis, which is a high pH, over 7.45, you see your PaCO2 is less than 35, and your bicarb is normal. Caused by hyperventilation, rapid respiratory rate, right? Blowing off too much acid. Usually anxiety, fever, overdose. If we have their respiratory rate too fast when they're ventilated, we can cause it. Head injuries can also cause it. Deep, rapid breathing, tingling fingers, pallor around the mouth, dizziness. We want to try to prevent further hyperventilation. Might have to give them sedatives to calm them. This is where we have them breathe into the paper bag and try to rebreathe carbon dioxide to get the recycled carbon dioxide to restore those acid levels in the blood. Metabolic alkalosis, again, high pH. You see that their PaCO2, their carbon dioxide is normal, but their bicarb is high. It can be caused by vomiting, gastric suctioning, too many antacids. They're going to have neurologic signs, irritability, disorientation. Respiratory, they'll probably have slow, shallow respirations, might have some cyanosis. If it progresses to tetany, they'll have tetany, seizures, and then coma. Tetany is severe muscle cramps, spasms, stridor. Again, we're going to try to restore body fluids, replace electrolytes. We might have to give them ammonium chloride. So we want to watch for fluid intake and restrictions, sodium restrictions. We're going to try to manage those underlying causes, and we're going to monitor, see what's happening with them. So IV fluid therapy. We have maintenance fluids. We have oral and parenteral replacement fluids, parenteral nutrition, blood and blood products, plasma expanders. These will be used for fluid volume deficit, electrolyte imbalances, acid-base imbalances, used to give meds, TPN. When we're administering IV fluids, our goal is to prevent infection, minimize any injury, make sure that we're giving the right fluid at the right time at a safe rate, and observe their reaction, because we want to be helping, not hurting. So we have to do the 6 rights with the IV solution also, okay? Ooh, where did I go? Holy cow. I don't want to do that. Right solution, right dose, right route, right time, right patient, right documentation. We're going to regulate the rates of flow. You remember how to do this? D over H times, mils per hour, drops per minute. For older adults, again, we don't want to give them anything too fast. We don't want to try to catch up and risk overloading them. So with IV therapy, there's a lot of things to watch out for. We always need to make sure we're following facility policy when we're doing anything with IVs. Here's some nursing diagnoses that go with it: deficient fluid volume, excess fluid volume, risk for imbalanced fluid volume, risk for injuries related to IV fluid administration, ineffective breathing, impaired gas exchange, lots of them. When we plan for what's going to happen with our patient, we want to make sure that our patient exhibits normal skin turgor. We want to try to maintain their weight. Our goal might be to restore the patient's fluid and electrolyte balance, right? We need to make sure we're monitoring their IV site for infection, redness, swelling, phlebitis, anything like that. Their implementation of their care, fluid and electrolytes, diuretics, daily weight, skin care, monitoring, these are all things we would have to do for our patient. And then we're going to evaluate the care that we did every 24 hours. We need to make sure we're evaluating and see if we're helping, hurting, if what's working, or something needs to be changed. So what I want you guys to do is make sure that you have read the video, or read the book, and are up to date on this chapter. We're going to be doing probably a case study in class, but we're going to be doing a little group assignment, and we'll discuss more about the metabolic acidosis, alkalosis, respiratory acidosis, alkalosis. We're going to talk more about the electrolytes. We're going to make sure that you guys know what you're talking about. So please read the chapter, watch the video, and then when we get to class, we can really get down to work.